All right, so I think at this time it makes sense. Why don't we swap on over to the interactive part of this session, where we would love to get your feedback and thoughts on, some of the cases. And I think maybe it makes sense to start with a polling question. And the polling question is, in July of 2021, this patient, this is the right eye of a patient with intermediate AMD, would you refer? So while we kind of get those polling questions, we do have a couple of questions that we can kind of get to in the meantime that some of you have posted in the chat. So I'm going to ask actually Dr. Haynes, do you measure the choroid with the calipers as a standard thing? That was one of the questions.
That's a great question. The choroid is definitely an important aspect of managing and diagnosing patients with macular degeneration. Patients with macular degeneration on average do tend to have a thinner choroid than certain other conditions that can cause RP defects, such as pachychoroidal syndromes. So it is nice to measure the choroid to get a sense, how thick is this? Is this more consistent with macular degeneration? Could this be more consistent with some other type of macular degenerative or macular disease? And also, patients with thinner choroids may be more apt to develop geographic atrophy, and those with geographic atrophy, they may be more prone to progress. So as far as measuring on each individual patient, I may not do that necessarily, because now I have my mental idea of what the choroid tends to look like, but it is a good practice to at least take note of the choroid, and you can use your calipers to measure it.
Yeah, I think that's a really great point. So if you look at this image here, you can certainly see that the choroid is thin. And one way to sort of estimate that is if you think about, as you get away from the foveal dip and you measure that retinal thickness and you compare that to the choroidal thickness, they should be kind of more or less about the same. So if you're underneath that choroidal thickness, or if the choroid is thinner than the retina, then that's one sort of like general eyeballing way of identifying that the choroid is thin. So, at this point, the audience has said that about 82% of patients would, 82% of providers would refer, and 18% would not refer at this window in time. And so, Dr. Majcher, why don't you show us a little bit about what happens to this patient over time?
Yeah, so here's the OCT scan from November 2021, and then also March of 2023. So a little under 2 years for this individual.
Yeah. And, so Dr. Haynes, what are your thoughts when you see somebody like this? What's going on here?
So in July 2021, we have this really large pigment epithelial detachment. In November 2021, that actually collapsed rather quickly. Patients at this point could actually have new metamorphopsias, or if you're using some sort of home monitoring device, could get an alert on their home monitoring device from a change like this. And some people may look at that and say, oh, this is a good thing. This large PD has collapsed. But unfortunately, what you see happening underneath there, you're getting more hypertransmission into the choroid. So your RPE is becoming weaker. And we spoke about this in one of the cases, but the natural progression of some of these lesions is that they will collapse, and then shortly after, they may start to develop geographic atrophy, which is essentially what happens to this patient going into March of 2023.
Yeah, so, as a piggyback to that, one of the audience members asked the question, with the advent of new meds for geographic atrophy, is it indicated to start treatment while the drusenoid PED still exists? And exactly, right. So like, in other words, in this case, in 2021, in July of 2021, would this person be a candidate for complement inhibition effectively? And for those who may not be aware, pegcetacoplan has obviously been FDA approved, and Avastin capsid pegol actually just recently got FDA approved. So now we have 2 treatments available, but both of them require sort of classical geographic atrophy. So as we start thinking about next generation, obviously we want to probably start thinking about treating patients a little bit earlier, and we sort of want to weigh the risk and benefits. But before we kind of get into that, I think, Dr. Majcher, maybe why don't we go on to the next polling question, because I think we want to kind of get your input on these cases. So here, Dr. Majcher, do you want to describe the images?
Yeah, absolutely. So this was a patient of mine. He's actually exudative in the right eye. And then here in the left eye, You can see we have this extrafoveal patch of geographic atrophy, even on the color fundus photograph here. And then on fundus autofluorescence, it's this well-demarcated area of dark hypoautofluorescence.
Yeah, so we'll wait for the audience polling as to would you refer this case?
You know, and while we're waiting, I'd like to comment on the first case that we threw out. I think there's a concern in terms of referral, not just for consideration of geographic atrophy like complement inhibition therapy, but also that large PED seemed to be like predominantly serous. And so when I think you're seeing something like that, it's important to refer to a retina specialist for perhaps fluorescein angiography or some sort of angiography to ensure that there's not neovascular disease there that would warrant anti-VEGF therapy, perhaps.
Yeah, and I think, and even if there's no exudation, to Dr. Major's point, if we see neovascularization underneath the RP, that would be defined as neovascular non-exudative AMD. And while we don't treat those patients with anti-VEGF therapy, those patients have a much higher risk of progressing to exudation. And exactly to Dr. Major's point, those are patients who may be perfect for home OCT monitoring or closer follow-up in the office. So we have some poll results here. About 65% of patients said they would refer, and 36% said no. So interestingly, based on these images alone, less of you would actually refer this patient. So why don't we look at one of the change analyses where we can get some information over time?
Yeah, so this is the Zeiss Advanced RPE sub-RPE slab analysis, and it's valuable in terms of giving us progression over time and even quantitative data to track what is the area of geographic atrophy and then how close it is to the center of the fovea. So if we look back at this patient, we can see what's been occurring over the past 1.5 years. The image I showed you is from this final follow-up. And you can see it's been slowly enlarging over time. I would say slowly, but especially over the last 6 months, it's actually quite rapid in terms of the expansion. It's been getting larger in size and it's been getting closer to the center of the fovea. And so does this change your mind in terms of should we refer this patient if this is the trajectory in which we're headed?
Yeah, I think that's a great point. So Dr. Haynes, at this point in time, what are your thoughts when you see something like this? Is this somebody you're worried about? Is this somebody you're going to be referring?
Seeing the change over time, and especially in the last 6 months or so, that is really compelling to refer the patient out. I think it is so interesting, like you mentioned, Carolyn, that more people would refer the initial patient with intermediate AMD than would refer this patient. And I think it's for so long we had such a fear of exudative AMD. But you look at something like this and you really realize this disease can progress faster than you think. And we should be concerned about this patient. That's not going to halt in its tracks suddenly. This is going to continue to progress.
Right. And the interesting thing is this is the classical type of patient who would have been enrolled in Derby and Oaks, the FDA registration studies that approved pegcetacoplan, or GATHER1 or GATHER2, which approved Avastin capsid pegol. So, and what's really helpful here is say you have a trajectory like this, it's really great to send that with the patient to the retina specialist so that the retina specialist can identify kind of what the change is over time, because that will also sway the decision as to whether or not treatment should begin.
Absolutely.
So I think, Dr. Major, I wanted you to sort of highlight again some of the sort of nuances of CRORA and IRORA, because I think that can be a little bit of a complicated thing. So let's just go over this in the last few minutes, just one more time here, because I think this is something that would be really, really helpful for all of us to understand.
Yeah, absolutely. With OCT imaging, we get high resolution images of the individual layers of the retina that are going to allow us to kind of stage geographic atrophy from the beginning to the end, right? And so when we're thinking about like full-blown geographic atrophy, we're usually calling that CRORA or complete RPE and outer retinal atrophy. And this classification of atrophy meetings group, or the CAM group, are defining this as an area of near complete RPE loss and photoreceptor loss that's at least 250 microns in diameter, associated with near homogeneous or like uniform choroidal hypertransmission into the choroid. Versus if we think about like something that's impending geographic atrophy or nascent geographic atrophy, that we now are kind of referring to as this more technical term of IRORA, incomplete RPE and outer retinal atrophy, where we have some degree of attenuation and disruption of the RPE and overlying photoreceptors, and that may be loss of the external limiting membrane or ellipsoid zone, such as this case here, some intermittent areas of choroidal hypertransmission that characterize kind of these early stages of areas that are likely to go on and progress to complete or CRORA over time.
Yeah, and I think that's such a great description. And this is something that we're all going to need to get really familiar with, because as time goes on, it's very likely what we're going to start doing is we're going to start wanting to treat patients with IRORA lesions before they progress on over to CRORA. So, there's been one question in the audience, which was, asking me specifically, have I been using Syfovre or Izervay? And the answer is, well, Izervay just got FDA approval, so I think it hasn't really come out to commercialization just yet. And for Syfovre, I had been using it, but that also brings us to the next question, which is these occlusive incidences. Now, I have not seen it in my practice. The good news is the prevalence of this is really quite low. If we think about endophthalmitis being 1 in 2,000, this is more like 1 in 10,000. But in those cases, they typically tend to occur in what we believe is after one injection. And so, this is always going to be something where we kind of hold our breath for the first injection and hope we don't end up in that rare event. But we have to kind of think about the risk-benefit analysis, and that may be personalized to the patient. So with that said, I think we're out of time here. I really wanted to thank Dr. Majcher and Dr. Haynes for their incredible work. It's always such a pleasure working with both of them. So thank you both so much. And, this is a relatively new program. The Ophthalmic ZEISS Medical Education Summit has only been here for about 4 years. So what we'd really like is your feedback, what you liked, what you didn't like, and how we can potentially improve this. So thank you so much all for being here. Good night. And I hope to do this again soon.